in volume overload, the volume is so high on the right side that the left ventricle is unable to maintain that circular shape in diastole.
Okay.
But in systole, it will return to its normal circular shape when visualizing from the short axis view. What you have to remember is you get the flattened D-shaped septum in diastole only for RV volume overload.
Hold on.
So here's a good example of if you were doing M mode through the short axis view at the papillary level. You're looking at this M mode, you can see that the septum is more flat during diastole versus systole.
Okay.
Make sense?
Yes.
Now we get to right ventricular pressure overload.
Okay.
So this is like a severe form of pulmonary hypertension. The difference between pressure overload and volume overload is that the septum will be flattened in both systole and diastole. The right ventricle will have like a circular shape in both diastole and systole. So on echo, you're going to have M mode that will have like a flattened septum in not only diastole but also systole. So on this M mode here, you can see that the septum is not only flattened in diastole here, but it's also flattened in systole. What causes this? Well, if you have a pulmonary embolism, or like if you have a DVT that embolizes, it's going to go to the pulmonary arteries and then essentially block off the lungs and causing volume and pressure to build up. Your right ventricle will enlarge. It will become hypertrophic because it's essentially working harder to push that blood through a smaller area. So these patients will have chest pain, obviously because there's a lot of volume in the heart, more than normal. So they'll get chest pain, they'll have shortness of breath, obviously because if they have a pulmonary embolism, it's blocking blood from going to the lungs to get oxygenated.
Right.
So they'll have a low oxygen level.
Okay.
So these are kind of the echocardiographic signs that you'll see. You'll obviously see a enlarged RV. It'll be hypertrophic. Your right atrium will be dilated. You'll see some TR, and you'll have a flattened septum. So here's another M mode here, and it's just kind of showing during diastole it's flattened, and also during systole it's flattened right there. Here's another great example. So I have these both side by side, short axis at the papillary level, and you can see that, so this is diastole, right ventricle, left ventricle. You can appreciate the D-shaped left ventricle. On your boards, you're going to want to look for flattened septum and D-shaped left ventricle. You could be asked what the right ventricle will look like in the short axis view, and you'll look for a circular shape. Yeah. Just like that.
Okay.
And then in systole, you can appreciate the septum is still flattened. It's almost pushed in here, making that crescent shape. On your boards, however, just look for flattened septum in diastole and systole.
Okay.
But when you're looking at it on echo, the pressure is so high, it's almost making the left ventricle completely collapse in systole.
Okay, but in systole and diastole, it's more important to see a flattened septum.
Yep,
right?
in both
Okay.
cycles, correct.
Okay.
And RV volume overload, you'll see a flattened septum only in diastole, not systole. It's very important to understand that it's impossible to have a flattened septum in systole and a round septum in diastole. Any questions on this?
No.
Okay. When you're calculating the QPQS, this is kind of a way to determine which way your shunt is going. Is it going left to right, or is it going right to left?
Okay.
So what you do is you have to measure, you have to get your stroke volume going out through your right ventricular outflow tract,
Okay.
and then you have to get your stroke volume going out through your left ventricular outflow tract.
Okay.
So you get those, and I believe you'll divide them together. QP stands for the pulmonic system, so the blood going out through the right side. And the S is the systemic. So S is the systemic, which is the left side, and P would be pulmonic, meaning the right side. So you'll get those. When you get your QP and QS, you'll divide them together, and if your number comes out to greater than 1, the shunt is left to right. If the number you get is less than 1, it's right to left.
Okay.
And that's bad. This one is bad. We don't want that. The reason is the left side pressure should always be higher than the right side. So a shunt, if someone just randomly got a shunt in their atrial septum, it's normally going to go from left to right because fluid will always travel in areas with less pressure. So blood will go from the left side, which is a higher pressure, to the right side, which is a lower pressure. So it'll go to the right side. What's that?
Fluid will always travel with areas of less pressure.
It'll travel to areas of less pressure.
2 areas. Okay. Less pressure. Okay.
And that's fine. It should flow from left to right.
Right.
But if for some reason resistance increases on the right side, so blood is unable to freely passively go to the lungs to get oxygenated and to go back to the left side, then pressure and volume will increase, thus making a shunt go from left to right to left.
Right. Okay. Okay.
And you'll see that in patients with Eisenmenger syndrome. So bubbles will cross from right to left during end diastole when you're doing a bubble study.
Right. Right.
And a PFO shunt will cross the septum during mid to end systole.
Okay.
That makes sense? Okay.
Yeah.
All right.
Oh, I hate this topic.
I know. We all do.
I actually saw a lot of questions on tamponade on like the test I took yesterday.
Yeah, I have quite a bit. I try to
A lot.
cover that
That's
as much
God
as possible.
damn it.
So tamponade is a condition where fluid builds up really fast in the pericardial space to the point where the heart really can't compensate. So the pressure, the intrapericardial pressure, will exceed the right ventricular diastolic pressures.
So the fluid builds up very fast in the pericardium where it cannot.
Yeah, so the heart can't really compensate enough or quickly enough.
Okay.
You'll scan patients, especially cancer patients who are on chemotherapy
Right.
or radiation therapy. They will build up fluid around the heart, but it doesn't accumulate as fast as someone who is in tamponade. You can have a large pericardial effusion that builds slowly, but will not show signs of tamponade. It's important to know with tamponade, you can only diagnose this condition clinically. And we use ultrasound to kind of confirm what was found clinically.
Okay.
That means the Beck's triad. The first one's called hypotension, then jugular venous distension, and thirdly, muffled heart sounds. Have you ever seen jugular venous distension before?
No.
What it means is the jugular vein and the neck will distend out. And that's because pressure is building up. Then muffled heart sounds, if you were to put a stethoscope on the patient's chest, you would hear muffled sounds. So you know the three layers of the pericardium, right?
Hmm.
So we have the visceral pericardium, which is the most inner portion or inner layer. This is also called the epicardium.
Yes.
So this is the epicardium. Then we have the pericardial space, which is just a potential space. And by the way, if you're asked what's the normal amount of fluid in the pericardial space, it's around 40 mLs. Then we have the parietal pericardium. So if you're asked where would you find fluid in pericarditis or in a patient with tamponade, and you're going to look for in between the visceral pericardium and the parietal pericardium, or the epicardium and the parietal pericardium. And then the fibrous is the very outer portion of the pericardium. What you have to know for your boards is, what does tamponade do when a patient breathes in and breathes out? So pathophys, what it does to the body, it's going to decrease LV stroke volume, and it's going to increase RV stroke volume. During inspiration, the intrathoracic and intrapericardial pressures will decrease. So this is when they're breathing in. Then blood flow will increase higher on the right side and will decrease lower than normal on the left side. So in the normal heart, so normally when a patient breathes in, or anyone breathes in, blood will flow through the tricuspid valve a little faster and will slow down a little bit on the mitral valve, through the mitral valve. during inspiration. And then the opposite happens during expiration. But with tamponade, it's going to be more augmented. So blood flow on the right side will increase quite a bit more, and the mitral valve velocities will decrease quite a bit during inspiration. Then during expiration, blood flow will decrease dramatically on the right side and will increase higher than normal on the left side. Then the septum is going to move to the left and posteriorly during inspiration, and it'll move to the right during expiration. So board question alert, if you're asked the most common cause of cardiac tamponade, you look for idiopathic. And idiopathic means of unknown origin. We learned about the physical signs. This is the Beck's triad: hypotension,
Right.
distended jugular veins, and quiet heart. And then we have pulsus paradoxus. So pulsus paradoxus is when there's a greater than 10% decrease in the arterial systolic pressure during inspiration. So some of the echo signs, you're going to have obviously the large pericardial effusion. Then the right ventricular chamber will collapse during end diastole or during atrial systole, because atrial systole occurs at the same time as ventricular diastole. Just in case you get a question of when would you see RV end diastolic collapse and they didn't have ventricular diastole but they had atrial systole, just know that would be an appropriate option if you didn't have ventricular diastole. So it's important to know that in early diastole, after the pulmonic valve closes and when the tricuspid valve opens, the right ventricular outflow tract will paradoxically collapse. So this is talking about diastole with a lot of words. When you're running your Doppler through your tricuspid valve and have them breathe in and out, you're going to see that greater than 25% variation in both the tricuspid and the mitral valve. So here, you can see that in this image, they're imaging or they're evaluating the mitral valve, and then here is the tricuspid valve. So you can see during expiration that blood flow is increasing through the mitral valve quite a bit,
Right.
and then decreases quite a bit during inspiration. Increasing during expiration, then decreasing during inspiration, increasing during expiration, then decreasing during inspiration. This is the mitral side.
Okay.
Then on the tricuspid side, you can see that here's a little waveform here indicating inspiration and expiration. So on the tricuspid side, velocities will increase during inspiration, then decrease during expiration, increase during inspiration, decrease during expiration, so on and so forth. So at the end of inspiration, when velocities were the highest, then the patient started to breathe out, which means the blood flow will start to decrease through the tricuspid valve. So you measure that one, and then you will measure the waveform after the patient breathes in. You want to make sure that your sweep speed is turned down way low so that you can fit way more waveforms in here. So here's a little diagram here indicating what happens during expiration. So during expiration, blood flow through the mitral valve will increase and tricuspid valve inflow will decrease. And then during inspiration, you're going to have blood flow increase through the tricuspid valve and decrease through the mitral valve. The treatment for tamponade is a pericardiocentesis. That's the only thing you can do because if this isn't treated quickly, the patient could go south really fast. And that's why if you ever are called to do an exam and there's like
Right.
3 or 4 stats and one says cardiac tamponade, you always do that one first.